If you are taking a small pill every single morning for your blood pressure and you are still feeling completely exhausted, gaining weight around your middle, or struggling to climb a simple flight of stairs without feeling winded, there is a very real chance your doctor has you on a beta blocker, and the latest science is telling us something that most physicians still have not caught up with. That medication you have been taking faithfully every morning may actually be working directly against your health. And this channel exists to bring you the latest evidence-based research on senior health, simplified and designed specifically for adults over 60. If you are not subscribed yet, hit that button right now because what I am covering today could completely change the conversation at your very next doctor's appointment. Beta blockers. You probably know them by their brand names, Metoprolol, Lopressor, Tenormin, or by their generic names, Metoprolol and Atenolol. These medications have been prescribed for high blood pressure for over 5 full decades. Doctors write tens of millions of prescriptions for them every single year across the country. They are inexpensive, they are familiar, and for a very long time they were considered the absolute gold standard for treating hypertension in older adults. Here is the problem. The research has moved on significantly, and for many seniors with uncomplicated high blood pressure, beta blockers are no longer the best available choice and may actually be making several serious things worse at the same time. Let me explain exactly what a beta blocker does inside your body so this all makes complete sense. Your heart has receptors on its surface. Think of them like locks on a door. Adrenaline is the key that fits those locks perfectly. When adrenaline connects, your heart beats faster and harder. Beta blockers sit inside those locks so the adrenaline cannot get in at all. That slows your heart rate and reduces the force of each beat, which brings your blood pressure numbers down. That sounds completely reasonable. And for certain specific conditions, recovering from a heart attack, managing heart failure, treating dangerous heart rhythms, beta blockers are genuinely life-saving medications. We are not questioning their value in those situations at all, but for run-of-the-mill high blood pressure and otherwise. Healthy seniors, the evidence has shifted in a very dramatic way. The turning point came with a landmark study called the ASCOT Trial, the Anglo-Scandinavian Cardiac Outcomes Trial, published in the Lancet Medical Journal. It followed over 19,000 patients with high blood pressure and compared those taking a beta blocker plus a diuretic against those taking a calcium channel blocker plus an ACE inhibitor. The trial was actually stopped early because the results were that clear and that significant. Part 4. The shocking results: the group on beta blockers had significantly more strokes, more heart attacks, and more new diagnoses of diabetes than the other group. The calcium channel blocker group had 23% fewer major cardiovascular events, 23%, that is not a small or minor difference by any measure. Following that study and several other confirming studies published afterward, the United Kingdom's National Institute for Health and Care Excellence formally removed beta blockers from their recommended first-line treatment for hypertension. Yet millions of Americans remain on them as their primary blood pressure medication today, often because their doctor prescribed it years ago and nobody has ever revisited that original decision since. Comment below right now. Are you currently taking Metoprolol, Atenolol, or another beta blocker for your blood pressure? Just yes or no in the comments section. I want to understand exactly how many of you this situation is currently affecting. Now let me walk you through the specific ways these medications may be working against your body, particularly if you are over the age of 60. This is the part that most doctors simply do not take enough time to explain to their patients during a standard appointment. The first major issue is fatigue and exercise intolerance, and this one matters far more than most doctors are willing to acknowledge openly. When you block the adrenaline receptors in your heart, you limit how high your heart rate can climb during physical activity. For a younger person sitting behind a desk all day, that ceiling may feel completely invisible to them. But for a 65-year-old who wants to walk the neighborhood, swim laps, or simply keep up with grandchildren, that limitation means you hit a wall much sooner than you should. You feel winded faster. Your legs feel heavy and uncooperative. Exercise feels dramatically harder than it should feel for someone your age and fitness level. And because physical activity is one of the most powerful tools we have available for naturally lowering blood pressure, tolerating it less well creates a deeply frustrating cycle. The medication makes exercise harder. Less exercise means your blood pressure stays elevated regardless. And so the cycle continues without resolution. Harold was 71 years old when he came in reporting fatigue so profound that he had stopped his evening walks entirely. He had been on Atenolol for 3 full years. In that time, he had gained 14 pounds. His blood sugar had drifted into pre-diabetic range, and his energy was what he described as running on half a tank all day every day. His previous doctor had simply attributed everything to normal aging. The second major concern is metabolic damage, and this one is extremely well documented in the medical literature. Beta blockers increase insulin resistance and raise triglyceride levels while simultaneously lowering your HDL, which is your good cholesterol. A comprehensive analysis published in the Journal of the American College of Cardiology found that patients on beta blockers had a 22% higher risk of developing type 2 diabetes, compared to those on other blood pressure medications. For seniors already managing blood sugar or sitting in that pre-diabetic gray zone, that is a genuinely meaningful risk to be adding with a medication that is not even outperforming its available alternatives. Here is what genuinely surprised me when I worked carefully through this data. Beta blockers often do bring your blood pressure numbers down on the surface. The cuff reading looks perfectly acceptable to both you and your doctor. The problem is what is quietly happening underneath those numbers: the metabolic disruption, the cardiovascular outcomes over time, the slow and steady erosion of your overall quality of life. You can show a reading of 128/78 and still be quietly accumulating real harm if your medication is simultaneously working against your metabolic health at the same time. Third, there is the fall risk issue that is critically underappreciated in older adults taking these medications daily. Beta blockers can cause orthostatic hypotension, which is a sudden drop in blood pressure when you stand up from a sitting or lying down position. That brief dizzy feeling you experience when you rise from a chair may feel like a minor inconvenience to you, but for a 73-year-old, that is not just uncomfortable. That is a serious injury waiting to happen. Hip fractures in seniors over 70 carry a one-year mortality rate approaching 30%. A medication-induced fall is never just a simple fall. Before I tell you what the research supports as better available options, I need to make something absolutely clear. And this information could genuinely protect your life. Never stop a beta blocker on your own without direct medical supervision. Stopping abruptly can trigger a dangerous rebound effect, causing your heart rate and blood pressure to spike rapidly. In some cases, this rebound can trigger a serious cardiac event or a dangerous heart rhythm problem. Any transition away from these medications must be supervised by a qualified physician and done gradually over a period of several weeks without exception. What I am giving you today is information and carefully prepared questions to bring to your doctor at your next appointment. This is not permission to open your medicine cabinet and make independent unilateral changes to your prescription without medical guidance. Please treat this information exactly as it is intended, as education, as preparation, as the starting point for a much better informed conversation with your healthcare provider. That conversation could genuinely change the direction of your health in a very positive way. Now, what does the current evidence actually support as better alternatives for seniors with uncomplicated hypertension? Two medication classes stand out very clearly in the research. The first is calcium channel blockers. Amlodipine is the most commonly prescribed medication in this class. The ASCOT data strongly favored this class over beta blockers for overall outcomes. It does not carry the same metabolic risks. It does not limit your exercise capacity in the same problematic way. A large analysis published in the British Medical Journal confirmed that amlodipine was associated with significantly lower stroke risk than atenolol in elderly patients with high blood pressure. The second strong alternative class is ACE inhibitors and their closely related class, ARBs, which stands for angiotensin receptor blockers. Medications like lisinopril, ramipril, losartan, and olmesartan have shown consistent benefit in senior populations with protective effects for kidney function. They also show better outcomes in patients managing diabetes alongside their blood pressure, and they carry a notably lower fall risk profile than beta blockers. ACE inhibitors do cause a persistent dry cough in approximately 10 to 15% of patients. If that happens to you, an ARB is generally the better choice and works through a very similar mechanism without triggering that cough. Dorothy was 74 years old when her cardiologist revisited her long-standing beta blocker prescription and transitioned her gradually over 8 weeks to amlodipine combined with losartan. Within 3 months of completing that transition, her fasting blood sugar had fully normalized. She had lost 7 pounds without making any intentional dietary changes whatsoever. She described feeling like herself again for the first time in several years. Her energy had returned, her walks felt easier, her mornings felt different, and her blood pressure readings were actually more consistent and more stable than they had ever been while she was on her previous medication. So here is exactly what you should do with this information starting today. First, look at your current medications and identify whether you are taking a beta blocker specifically for blood pressure control, not for a diagnosed heart rhythm problem, not for post-heart attack management, not for heart failure, but purely and specifically for hypertension alone. The medication names to look for are Metoprolol, Atenolol, Bisoprolol, Propranolol, and Carvedilol. Second, write down 3 specific questions before your very next appointment and bring them with you on paper. Ask your doctor this: was my beta blocker prescribed specifically for hypertension, and does that still reflect current evidence-based guidelines today? Ask, have we evaluated my fasting insulin levels and my triglyceride levels recently as part of my overall health picture? And ask, would I be a strong candidate for transitioning to a calcium channel blocker or an ARB based on my complete and current health profile? Third, request a formal and thorough medication review at your next visit with your physician. If you have been on the same blood pressure medication for more than 2 to 3 years without any formal reassessment, you are absolutely entitled to ask for one. Many seniors today are taking medications that were considered standard of care back in 2005 and have since been significantly reconsidered by updated medical evidence and research. You deserve a medication plan that reflects where the science actually stands today, not where it stood 2 decades ago. Fourth, if any medication transition is recommended by your doctor, confirm the full tapering schedule with them before you begin. A responsible physician will reduce beta blockers gradually, typically over a period of 4 to 8 weeks, and will monitor you carefully throughout the entire process. Fifth, begin tracking your own symptoms starting right now. Keep a simple daily log of your morning blood pressure reading, your energy level on a scale of 1 to 10, and your fasting blood sugar if you are currently monitoring it. 3 to 4 weeks of your own consistent personal data gives your physician something genuinely concrete to work with and makes the entire conversation far more productive and focused. One important clarification before we close today, because this distinction genuinely matters for your safety. There are absolutely patients for whom beta blockers remain the correct and most appropriate medication for their specific situation. If you have coronary artery disease, a history of heart attack, diagnosed heart failure, or certain heart rhythm conditions including atrial fibrillation, the full calculation is entirely different for you. The evidence supporting beta blockers in those specific conditions is solid, well-established, and should absolutely not be dismissed. The concern we have discussed today applies specifically to seniors whose only diagnosis is hypertension without any accompanying cardiac condition. If your blood pressure medication is leaving you exhausted every day, if your weight is slowly creeping upward, if your blood sugar is trending in the wrong direction, and if your prescription has not been reviewed in years, you now have the research, the specific language, and the exact questions needed to walk into that next appointment completely differently. You deserve a treatment plan that is built on current evidence and not on decades-old prescribing habits that the medical community has long since moved beyond. Comment the words "reviewing mine" if you are planning to bring this information to your doctor at your next visit. Comment your current blood pressure medication below as well. I read every single response, and your question may very well become the topic of a future video on this channel. If someone you care about is struggling with their blood pressure management right now, please share this video with them today. One conversation armed with the right information can genuinely and meaningfully change health outcomes.